Went to medical school here, and then left us. She went to Dartmouth. She did her residency there, pediatric residency, and her neonatal fellowship there. You will notice I am wearing a Dartmouth tie. This is the Children's Hospital at Dartmouth tie that I got when I went out to recruit her and to give grand rounds there. So just a little commemorate. I could make you wear this tie. Kari joined us in 2005. She's an assistant professor. Her area of research and also teaching interest is exactly what you're going to hear today. This is a very translational talk. She is the director of clinical research on the NICU. She's also the director of the neonatal SIM portal teaching module that we have, and has really been the pioneer for that. She's on the board of directors for SIM portal. She's well known around the country for her work in NRP and also for a very innovative trial that she conceived and multi-center trial that she is spearheading on LMA surfactant delivery to preterm babies. So you're going to hear a nice translational talk here titled Helping Babies Breathe Better, very alliterative, from intubations to innovation. So Kari, welcome.
All right, thank you. So it's not titled just Helping Babies Breathe, because that's actually the name of the, is that Michael's? All right. So Helping Babies Breathe is actually copyrighted by the Newborn Resuscitation Program for their international program that they've just launched for third world countries. So I couldn't title it Helping Babies Breathe. I had to put Helping Babies Breathe Better. So we'll talk about intubations to innovations, as Michael said. Let's see. In terms of disclosures, the research that I'll talk about at the end is supported through Cornerstone Therapeutics by their supporting the CuraSurf that we're using for the research. And I'm also on the Speakers Bureau for Cornerstone Therapeutics. And I will talk about off-label use of the laryngeal mask airway for surfactant administration. The LMA is FDA approved for airway device as a ventilation device for neonates, but is not FDA approved for medication administration. Looking at the objectives for today, we'll take a brief look at the historical background, embryology and physiology of pain in neonates. Look at the adverse effects of endotracheal intubation and the importance of using premedication to blunt those adverse effects. And then look at the innovative use of the laryngeal mask airway for surfactant administration. This is one of my favorite quotes. It's by Dr. Catwinkle. He's the editor-in-chief of the Newborn Resuscitation Program and also a neonatologist. He states that birth is a beautiful, miraculous, and very personal event for all involved. But it's also probably the single most dangerous event that most of us will ever encounter in our lifetimes. Now, this is very true for full-term babies, but it's even more significant for babies who are born preterm. Now, sick neonates are among the most vulnerable members of our society. They have no ability to protect themselves, no ability to ask for something to ameliorate their pain, and no ability to protest about their painful experiences. However, they are subject to numerous painful procedures in the NICU. In laundry list here, they're all very necessary, but also very painful. They include heel sticks, venipunctures, LPs, line placements, chest tubes, intubation, suctioning, and injections. For those of you who work in the NICU or have been through the NICU, you'll notice that this picture is not taken from our NICU, because you'll notice the stuffed animal in the warmer. And Tom George is not here, but he became known as Toyless Tom when this policy was being implemented, because he was very against stuffed animals in the warmers. Pain in newborns is often unrecognized and undertreated. In a survey of Canadian NICUs that looked at 240 babies, they found that almost over 2,100 invasive procedures occurred over a 1-week period of time. This is approximately 9 procedures per baby per week. And in the late 1990s, when the survey was done, less than 1% of the time babies were given pain medication for these procedures. Looking at the historical background, in the 1970s, there was a widespread belief that newborns did not feel pain. There was rudimentary knowledge of how to safely anesthetize infants. There was a belief that the dosage requirements of anesthesia needed for neonates was much, much greater than that for older children and adults. There was a fear of hypotension and bradycardia with anesthesia. And there was inadequate monitoring equipment, for there was no oximeters and no EKG monitors. And this type of equipment didn't come into the NICU until the 80s. Fortunately, there's been a major change in the beliefs and attitudes about neonatal pain. And here's just kind of a brief description of how these attitudes have changed. In the late 1980s, there was a survey done of pediatric anesthesiologists, and about 13% believed that newborns did not feel pain, 7% believed that neonates did not feel pain, and about a quarter of them were undecided. However, when the study was repeated in 1996, there was universal agreement that newborns and neonates did feel pain. This is kind of a busy slide, but again, it shows the difference in just even less than 10 years in their attitudes towards pain. This, again, is the pediatric anesthesiologists, the same survey that we just talked about in the last slide. And this was broken down by how they felt based on how old the baby was. The baby was less than 1 week of age and underwent a major surgery. This was whether or not they received opiates or pain medication for this major surgery. In 1988, if a baby was less than 1 week of age, less than 5% would actually receive pain medication for a major surgery. But this number bumped up to less than 90% by 1996. The numbers are a little bit better in 88 for if you were 1 week to 1 month, with being about 15%, but again, being just less than 90% in the 1996 survey. 1 month to 3 months was about 50 to 60% for both years, so unsure why that age range was lower to begin with and didn't see much of a bump. And if you're 3 months to 1 year of age, that's when pediatric anesthesiologists started to feel more comfortable with giving you pain medication. So do newborns feel pain? Looking at the embryology, at 6 weeks of development, that's when the sensory neurons begin to synapse with the interneurons of the dorsal horn of the spinal cord. These sensory neurons grow peripherally. By 7 weeks, they start to innervate the perioral area in the face. By 15 weeks, it's spread to the trunk and the proximal arms and legs. And by 20 weeks, the remaining cutaneous and mucosal surfaces are innervated. Again, I want to stress here, by 20 weeks, the peripheral and ascending pathways are mature. And again, stress the ascending pain pathways are mature. The number of nociceptive or pain-sensing nerve endings is equal to or greater than the density of those in the adult skin. However, the pain inhibitory tracts are not fully functional, so there's actually increased transmission of painful stimuli. In addition, the dopamine and norepinephrine is not available to modulate pain until approximately 36 to 40 weeks gestation, and serotonin is not released until the 6 to 8 weeks after birth. If tissue damage occurs, this leads to dendritic sprouting, resulting in hyperinnervation of the wounded area that cannot last into adulthood. As a result, newborns may actually experience more pain than adults. So newborns feel pain. So what can we do to improve their experience? And today we'll focus just on intubation. Tracheal intubation is a procedure that's frequently performed in the NICU. It's often part of the initial resuscitation or performed emergently for apnea. However, it's also frequently performed on a semi-elective basis for air leaks, worsening respiratory distress, accidental extubation, or prior to surgical procedures. The current practice has a very wide range of current practice. It ranges anywhere from awake intubation, in which the baby receives absolutely no premedication, to any number of combination of medications. Looking at the physiologic effects of intubation, the heart rate itself, bradycardia, has been reported in response to awake, again meaning absolutely no premedication whatsoever, and anesthetized intubation, with the bradycardia being associated with laryngeal stimulation and increased vagal tone. This bradycardia can be prevented by the use of atropine, and this is very important when we think about how our babies are dependent on their cardiac output. because the cardiac output is equal to their heart rate times their stroke volume, and their stroke volume is relatively fixed. So the heart rate is very, very important for maintaining their cardiac output. Looking specifically at blood pressure, awake intubation causes fluctuation in blood pressures and an acute hypertensive response. In a study done on neonatal piglets, they found that the blood pressure increased almost 50% with intubation, and this elevation remained for up to 14 minutes. In a study replicated on human preterms, this was very similar, with an increase of almost 50% when the trachea was intubated. They also found that this blood pressure increase could be modulated by premedication. And Kamash looked at if atropine alone was given, the blood pressure increased by about 20%, but if a combination of atropine, fentanyl, and succinylcholine was given, the blood pressure increased by only 4% above baseline. Looking at oxygen saturation, awake intubation is associated with more severe and prolonged hypoxia. Is that Michael? Anesthesia and paralysis reduces the number of attempts and time to successful intubation, thereby reducing the severity and duration of hypoxia. This is a laundry list of some of the studies that have been done looking at the time and number of attempts that it's taken to intubate. Again, you'll notice that it varies in the number of the different combinations of medications given, with some looking at awake versus different combinations. And I want to focus on the last two. OE looked at awake, again, no premedications, versus a combination of atropine, morphine, and succinylcholine. And there was almost a 10-fold decrease in the number of time and the amount of time that it took to intubate. And Barrington looked at the successful or consecutive intubations after implementing a routine use of atropine, fentanyl, and succinylcholine, and found that 88% of the time they were successful on their first attempt. In terms of intracranial pressure, changes in the anterior fontanelle pressure reflect changes in the intracranial pressure. Friesen found that if atropine alone was given, there was an increase in the anterior fontanelle pressure of almost 200%. But if a pancuronium or a paralytic was given, there was no change in the anterior fontanelle pressure. Barrington found the same results, where there's a significant increase if atropine alone was given, but no change if a paralytic was added. And Millar found very similar results. This is a graph from Millar's study that looked at the different steps in intubation. The filled-in circles, or the closed circles, are the anesthetized group. The open circles are the babies that receive no premedication. And the spike in the spike in the anterior fontanelle pressure occurs at event number 2, which is the placement of the laryngoscope. So a summary of the physiologic effects of intubation include bradycardia, hypertension, hypoxia, and increased intracranial pressure. And these effects can be blunted with premedication. Atropine blocks the bradycardia associated with the laryngeal stimulation. Muscle relaxants attenuate the increase in intracranial pressure. And a combination of atropine, an analgesic, and a muscle relaxant maintain the physiologic parameters closest to baseline. But what are the pros and cons of premedication? The pros are that it takes less time to intubate. There's more successful first attempts. There's a decreased frequency and duration of hypoxia. It blunts the hypertensive response, avoids increased intracranial pressure, and most feel it's more humane. However, it does take time to insert an IV if you don't already have one. It takes time to drop the meds, takes time to administer the meds. Some would argue that you're trading one painful procedure for another if you have to insert an IV. And then the biggest is that there's a risk of adverse effects with analgesic. If you've ever experienced rigid chest with fentanyl administration, it's something that you never want to experience again. And there's also the major concern of airway concern if you can't get the baby intubated if you have a paralytic on board, because you've just taken away their ability to spontaneously breathe. So valid concerns with premedication, but also very valid pros. Is premedication safe? This is the study that I mentioned earlier, where they looked at 253 consecutive intubations after implementing their routine policy for using atropine, fentanyl, and succinylcholine. They found that 77% were without incident, and 11% required 2 attempts, which they considered an incident. 9% required 3 attempts. 4% required a smaller ET tube, and 1% or 4 babies had rigid chest, of which 3 resolved with succinylcholine administration. Keith Barrington is the author of that study. He's a neonatologist in Canada, and he's very, very vocal in terms of the use of premedication. He states that it is inconceivable that we should ever go back to a practice of allowing infants to gag or cough, gag, choke, and struggle against a laryngoscope and endotracheal tube. And this was in 1998. So it sounds like premedication is a good idea. Is anyone using it? We'll look at 5 surveys quickly here. Just quickly, in 1992, 100% denied the use of atropine, which again is very important in terms of keeping your heart rate up. Very few were using an analgesic, and very, very few, only 3% were using a paralytic. By 2000, about a third were using some pain medication, and a quarter were using a paralytic. And in 2000, a study of over 260 neonatologists in Canada, they broke it down by groups in terms of how comfortable they were using any type of premedication. And as you get older, they become a little bit more comfortable. And the reasons for not using premedication were insufficient evidence, no need, and lack of comfort. And again, this premedication does not necessarily mean that they're using the triple cocktail. It just means that they're giving something. The most recent that's been published is in 2006. It looked at 78 university-affiliated NICUs in the United States and found that premedication was always being used 44% of the time, sometimes 28%, and never 28%. So again, almost a third of the time, babies are not getting premedication as recently as 2006. Atropine was used about 16% of the time. Analgesics, this is the breakdown of what people were using, with morphine or fentanyl alone being most common. The use of Versed is kind of smattered in there. And then a paralytics, mivacurium was absolutely beautiful. It had a very rapid onset. Its offset was about 15 minutes, so it was perfect for intubations. However, it was taken off the market because it was very expensive to produce and had a very small market. Succinylcholine is used very frequently. However, it does have a black box warning that it should not be used in kids because of the risk of malignant hyperthermia. Avec and pancuronium are okay, but they have a long duration. And again, the triple cocktail of atropine, and analgesic, and a paralytic in 2006 was only used 12.5% of the time. So with this in mind, it led to a background research of premedication for non-emergent neonatal intubations. This was my fellowship research project, and I compared atropine and fentanyl to atropine, fentanyl, and mivacurium. So everybody got atropine and a pain medication. The only difference was whether or not they got the paralytic. It was a randomized controlled trial. It was the site where I did my fellowship at Dartmouth, and also the University of California at San Diego. It was all comers to the NICU who required non-emergent intubation and had IV access. We enrolled 41 babies from 2003 to 2005. And again, the two groups only differed by whether or not they got the paralytic. The cart is very similar to the cart if you've been in the NICU that we're using currently, just a very old version now that included a video camera, pulse oximeter, and a computer. And so we were able to videotape the procedure and also gather the heart rate and saturation data and then correlate those so we could have them on the same screen and see exactly what was happening with the baby and the baby's physiologic parameters. We looked at the time and number of attempts as well as the duration of mivacurium, because mivacurium had very little data in babies, and also for potential areas of improvement in terms of the intubation procedure itself. Let's go quickly through this, but again, it was all comers to the NICU who needed non-emergent intubation. So our average was about 30 weekers, but they ranged from 24 weekers to post-dates babies. And we were a training center, so we let all levels of intubators intubate, with interns and residents being allowed to intubate 2 times before a senior level provider would intubate. Looking at the results, the heart rate, the change from baseline was similar between groups, which is expected because the atropine was given in both groups. And this made me a real believer in terms of giving atropine to all babies that are being intubated. In 4 babies, they had saturations less than 40%, and all babies, their heart rate was greater than 100, other than the 5 out of the 6, but the one baby had a heart rate of 96 as the lowest heart rate. So again, this made me a total believer in the need for atropine. Blood pressure, similar between groups, again, very expected, as both groups received atropine and fentanyl. And then looking at the time and number of attempts, and this is where we really thought we were going to see the meat of our results, because the difference in whether or not they received a paralytic. If you've ever tried to intubate a baby, the hardest thing to do is intubate a moving target. And so we looked at the saturations, and we chose thresholds that we thought were clinically significant. So we looked at the dichotomous of whether or not they had any saturation, less than 85, 75, 60, or 40, whether or not that saturation was greater than 30 seconds. So the first one was even if it was less than a second that they hit below that saturation, that was counted. But the second one, they had to be longer than 30 seconds to have that count against them. And then the third was actual duration of time in terms of seconds. We also looked at the time. We found that the successful intubation, 472 seconds is almost 8 minutes versus 144 seconds, which is about 2.5 minutes. And then the time that the total laryngoscope time, so what we did for total successful intubation is that time started with the very first time the laryngoscope was placed in the mouth. It ended when the laryngoscope was taken out after successful intubation. And so if there was multiple attempts during that time, the time ran continuously. Whereas total laryngoscope time was just the summation of times that the laryngoscope was in the mouth for multiple attempts, if there was such. The attempts results was the number of times that the baby was successfully intubated in 2 or fewer attempts. And we also looked at complications. So we looked at difficulty with bag mask ventilation. Again, both babies received fentanyl. And again, as I talked about, if you've ever experienced rigid chest with fentanyl, it is relieved with a paralytic. 1 baby had a pneumothorax, 2 babies had mouth lacerations, and 1 baby had aspiration. And then we looked at the duration of mivacurium, because again, there was very little data at that time on babies, the duration of mivacurium in babies, and we found that it wore off in about 11.5 minutes, which was perfect for our situation. So in summary, there was a difference in the incidence of the amount of time that the baby spent below 60% on their saturations. There was a 3-fold decrease in the total procedure time, a 2-fold decrease in the time that the laryngoscope was in the mouth, and the babies were successfully intubated twice as often in less than or equal to 2 attempts. This was published in Pediatrics in 2006, and since then it's been cited several times. But the 2 things that I'm most proud of in terms of this study is that it's been cited most recently in Pediatrics in 2010 as the consensus statement by the American Academy of Pediatrics on the use of premedication in neonates. And it states, except for emergent intubation during resuscitation, either in the delivery room or after acute deterioration or critical illness at a later age, premedication should be used for all endotracheal intubation in newborns. And also most recently in 2011 is the Canadian statement, the Fetus and Newborn Committee on their statement on premedication. And it states that all newborn infants should receive analgesic premedication for endotracheal intubation, except for emergency intubation during resuscitation, or infants in whom instrumentation of the airway is likely to be extremely difficult. So premedication decreases adverse effects of intubation, but can intubation be avoided altogether? So with that in mind, it led to the thought that if we could avoid it altogether, that would be even better than blunting any adverse effects. So the thought came about that as an EMT in college, I had used the laryngeal mask airway in adults, but it just recently come into play in the NICU, and thought, wouldn't it be great if we could actually give surfactant to these kids just to get them over the hump, if they're kind of on the gray zone where they're working hard, but wouldn't it be great if they could just get some surfactant and see if they could just remain on CPAP. And so we tried it in the animal model first. But going back to the LMA itself, it was developed in 1981. It was used in the adult and pediatric populations for several years. But as I stated, it's just kind of made its way into the neonatal population over the past several years. There is literature on its use in difficult airways, especially in babies that have pural band or very small jaws. It has been used in routine neonatal resuscitation, but very, very little on that in the literature. Prolonged respiratory support, but that's never been its intended use. And in transport, and that's been very helpful for us in the field if we've been unable to get the baby intubated. This is what it looks like. It looks very, very similar to the endotracheal tube itself. The top part is exactly like an endotracheal tube, and the bottom part is fitted with a mask. The mask is inflated, and it has fenestrations that are very hard to see on this picture, but there's 3 fenestrations here that direct the ventilation down into the airway. This is a picture that shows where it's placed. This is the top part of the tube, and then I've colored the mask itself green. And so as you can see, when the mask is inflated, it then covers and protects against any type of reflux and forms a seal so that any type of ventilation is directed down into the trachea. It's also not gone through the cord, so that's the major difference between endotracheal intubation. So when we intubate, you need to use a laryngoscope and be able to see and place the endotracheal tube through the vocal cords further down into the trachea, whereas the laryngeal mask airway is just placed into the posterior pharynx and sits up above the vocal cords. It's primarily used for babies greater than 2 kilos. When I was talking with the company and developing my research project, they are not willing to give a bottom line weight, but we found that 2 kilos is pretty much where the literature stands. We've used 1,250 grams for our cutoff in our study, and we found that it's been very well tolerated in that size baby. And there is a case report of it being used in an 800-gram infant in the delivery room where they were unable to get the baby intubated. And they did use it for ventilation and epinephrine administration, and that baby did survive. And what they did in that case is they placed the LMA into the mouth, but they did not inflate the cuff. Looking specifically at using the LMA for surfactant administration, there's 2 papers in the literature. The first is a case report of being used in 2 babies, one about 1.5 kilos and the other being over 3 kilos. And the other is a prospective study looking at 8 neonates between 28 and 35 weeks. In both cases, all babies were on CPAP prior, and in all cases, all babies had an improvement in their respiratory status without any complication. So with that, we embarked on our animal model. It's a randomized control trial. We looked at 24 piglets. They are 1 to 2 days of age, and that's very well correlated to a premature infant. We induced lung injury by normal saline lavage, which is very well mimicking a respiratory distress model in a preterm infant. Placed them on CPAP, and then we divided them up into 3 groups. The first had an LMA placed as a sham and received no surfactant whatsoever as our control. The second group had an LMA placed and received surfactant. And the third received an endotracheal tube and were dosed their surfactant through this endotracheal tube. And then after their surfactant or sham, they were all placed right back on CPAP. We hypothesized that if you received your surfactant via an LMA or an endotracheal tube, you would have the same increase in your PaO2 or same respiratory improvement, and that the time and number of attempts would be less to place the LMA as opposed to an endotracheal tube. The results. The bottom is the group that had an LMA placed but received no surfactant, and the diamonds are the group that received their surfactant via an endotracheal tube. The squares are the surfactant LMA group. And these 2 groups are statistically similar in terms of their improvement in their respiratory status as defined by their increase in their improvement in their PaO2 levels. And these were similar, and they were statistically different than the group that did not receive surfactant. So it's kind of a busy slide, but the groups were similar in terms of their heart rate, respiratory rate, blood pressure, and pHs, and that was because all pigs were anesthetized similarly with ketamine drips. In terms of time and number of attempts, the time to place the device was 19 seconds for the LMA versus 123 seconds on average for the endotracheal tube, and number of attempts was 1 versus 2 on average, and these were both statistically significantly different. In terms of saturations, we did exactly the same as we did for my prior study in terms of looking at 85, 70, 60 lowest sat and change from baseline, and found that there was statistically different variations in terms of whether or not you had an LMA or an endotracheal tube placed. And in conclusion, we found that there was improvement in oxygenation with LMA and endotracheal tube being equal. The LMA was 6 times faster to place and 2 times fewer attempts. And the LMA placement resulted in less saturation change from baseline. And this was published in 2010 in Pediatric Research. It was funded by the American Academy of Pediatrics NRP program, as well as Educational Research Committee at St. Paul Children's. And the surfactant for that study was donated by Discovery Labs. So with that, just wanted to make sure that they were equally effective in terms of delivering the surfactant through an LMA as opposed to our gold standard of through an endotracheal tube. So with that, we embarked on the human trial. It's a randomized control trial. Currently 4 centers are participating here, currently at the Amplatz, San Diego, St. Paul Children's, and Loma Linda, California. Total enrollment will be 144 babies. We're looking at the babies that are 28 to 36 weeks. So I really wanted to capture the babies that are strong enough to, for sure, be able to maintain their stamina on CPAP without intubation, and really just the pure RDS type baby. Again, the weight cutoff was defined by the size of making sure that the LMA fit in their airways. And the 36 hours old was because I really wanted them to be pure RDS also, and not something in addition. And then they had to be on CPAP with an FiO2 of 30 to 40%. And this has been the hardest thing in terms of enrollment. Because what we found is that a lot of our babies are coming in on CPAP on room air. And they're working hard, but they're not having an oxygen requirement. Or if they're having an oxygen requirement, they're collapsing and having atelectasis, and they're rocketing very quickly out of the 40% range and needing intubation. But what I really wanted to capture is the baby who's kind of in that gray zone and would benefit from LMA surfactant. So the 2 groups are surfactant via an LMA, or the control group who remains just on CPAP. So this varies significantly from the pig data where they got surfactant through an endotracheal tube. This, again, is the babies vary in just hanging out on CPAP versus getting an extra dose early of the surfactant through an LMA. This is because our current practice is that the baby is in a gray zone. We're going to wait them out and see if they can just maintain their respiratory status until their body can kick in and make their own surfactant at days 1 to 3. And so the control group, again, is maintained on CPAP. The study group is given surfactant via an LMA, again, if they're in the 30 to 40% range and their FiO2. And the primary outcome is whether or not they're intubated in the first 7 days of life. The treatment failure criteria is very strict, and so in order to get intubated in either group, you have to have 2 of the following. Either your FiO2 is greater than 40% for longer than 30 minutes, your CO2 has to be greater than 65, if you're on ABG or CBG, or greater than 70 for a VBG, and your pH has to be less than 722. The reason that we need to have 2 of the following, and that was highly debated, was because the babies that may be on 42% oxygen but have a CO2 of 50, you would not necessarily intubate. You'd wait those out. So again, highly debated, but that is why we decided that you needed 2 of those following 3 criteria. But we also needed to make sure that there was a way that a baby who really needed to get intubated was able to be intubated. So if you had 1 of the following, either recurrent or severe apnea, hemodynamic instability requiring pressors, or requiring repeat surfactant dosing at the appropriate time. So this means that if the baby was in the LMA group and got their LMA surfactant and required a repeat dose, then they would actually get their next dose via an endotracheal tube. And so if they were in LMA group and qualified for another dose, we would actually pretend like they never even got that or assume that the LMA did not work. And they would get their next dose via an endotracheal tube, even if it was earlier than their 12-hour period. An intubation deemed necessary by clinical provider. Again, this is kind of just an out, so that if the provider felt that it was very necessary, they would have a way to do this. Secondary outcomes, we're looking at FiO2 requirement with the hypothesis that if you get surfactant, you're going to be off of your oxygen and on room air more quickly than the babies who don't get surfactant. Same with the duration of CPAP. You're probably going to be off of CPAP more quickly. The number of surfactant doses, as well as the incidence of pulmonary air leaks. As you know, the risk of being on CPAP is a risk factor for having a pneumothorax, and so we think that the incidence of air leaks is going to be decreased if you can get off of CPAP sooner. And also looking at the incidence of chronic lung disease, severe IVH, and PVL. In addition, we're videotaping all the procedures, very similar to that study card that I showed you with the initial study done at Dartmouth. And so this has been a major kind of hurdle to get over with having people willing to be videotaped and also taking the extra time to pull out the cart and fire it up. But it's been a very, very important piece of actually looking at the physiologic changes as well as kind of what can be done and what actually happens during an intubation or during an LMA placement. Because what you think is happening is not actually what is happening. Time is very, very warped. And we found that in many of our studies. And when you watch the videos, when I review them with people, you say, like, how long do you think that was? And oftentimes people will say, like, 10, 20, 30 seconds. And it's actually a minute, 2 minutes, those type of things. So again, time is very, very warped in reality. So we're comparing, we're videotaping all placement of the LMAs, and then if anybody is getting intubated, we're also videotaping the endotracheal tube placement, and comparing the placement of the device and also how the baby responds during the surfactant administration, the two different devices, and looking at time, number of temps, heart rate, and saturations. As I said, total enrollment is 144. To date, we have 52 enrolled, so we're about a third of the way through enrollment. Anticipated enrollment is 3 to 4 years, and additional sites will be joining us in 2012. And this is why. These are babies that are not on the ventilator. They are either on room air or on a little bit of nasal cannula. So with that, I will close. These are the 4 sites that currently are involved, so special thanks to all the people. It takes a major team, as well as a lot of the fellows and staff are here, and they have really been the workhorses and put a lot of extra time, and so I thank them very much because they have, like I said, very generously donated a lot of time in terms of being willing to consent and pull up that cart. So, thank you very much. Oh, no.
That lovely tie that I got at Dartmouth, and we don't have an Amplatz tie yet. I'm not sure how you're going to wear it at University of Minnesota. At least not with that out.
Okay. That's sweet. Oh, thank you. That's very sweet. Thank you.
Questions for Kari? I've got one before they start. So do you imagine that in our kind of distributed system that nurseries, for example, or down in Redwood and so on and so on, that first of all, they would be able to do this procedure, and second, that it would be wise to do that procedure. Because one thing we don't know with these kids is whether we end up giving one dose and they're kind of one and done, or whether they end up being, the 3-dose kid who really maybe should have been intubated. So how are you going to sort that out?
Placing the LMA is very easy, but it also has a learning curve. And so whether or not it should be done or whether it could be done, yes, it could be done, but probably should not be done at outside hospitals at this point. Like I said, it's very easy to place. All you have to do is place it and push it down until it can't go any further and inflate. But I've done it many times now, and there's definitely a learning curve. And every every baby has been very, very different. There's times when it goes smooth, and it's just absolutely smooth. And there are times when it does not go smooth. And it's very difficult to know why. There's babies that I've done, it's taken me 2 or 3 times to place it. The first 2 times it's not been smooth, and they only recover. I've tried to adjust it several times, but they only recover once we take it out, bag them back up, and then the next time it's gone smooth as silk. And there's really been nothing that I've technically done differently. In terms of the administration of surfactant, the thing that I've been most scared about is that we're administering surfactant or a liquid above the vocal cords. So I've always been very, very cautious and very concerned that there'd be laryngeal spasm. We have not seen that at all. It did not occur at all in the animal model. And there's a physician that's been doing this for over 10 years in Italy in his unit, and they have not seen any problems with it. But it is absolutely a realistic, theoretic side effect and potential problem that would be very, very difficult, and it would be very life-threatening and only resolve with a paralytic and rapid intubation. So for those reasons, I think it's not going to be something that Red Wing or Wilmer should be doing. The type of a place that I think would actually be golden is Ridges and Southdale and those type of things. We round at those places, and there's probably 2 or 3 at all times during your week, at least 2 or 3 babies per week that would benefit from LMA surfactant.
Yeah, I was hearing that, and I had memories from my previous life when I was still practicing neonatology. So this concept of, giving this surfactant in kids that potentially need it, but not really intubate and put them on the mechanical ventilator has been all around. And people have dealt with that by giving that through the ET tube, just take it out immediately thereafter. So just wondering, the putting of the ET tube just through the glottis and putting the LMA, does it have so much benefit for the second versus the first in terms of physiologic impairment on agitation or whatever you want to put in this procedure? That's what I don't completely understand.
All of it is based on your belief in premedication. And so for the LMA placement, we give atropine because, again, you are stimulating that vagal nerve. And so we give atropine and Sweeties. So Sweeties is like a very concentrated sugar water that the babies really enjoy, and they just completely chill out. So if you believe in premedication, which I very strongly do, you no longer have mivacurium as a choice, so rapid offset in terms of your paralytic. And succinylcholine has the black box warning. So people in Canada are using succinylcholine as their rapid extubation in and out type thing. We are stuck with rocuronium that has about a 30 to 45 minute offset. So you can't get away with, if you're going to premedicate and believe that you should use a paralytic, you can't get away with not having them on the ventilator for at least an hour.
Yeah, well, that's what I was asking. So with this, the discomfort of putting the LMA, it doesn't need premedication?
No, we found that the babies are completely chilled out with just the atropine and Sweeties. The bigger the child, there's been a couple that have been more full term, or like the 34, 35-ish, weekish type baby, that they don't like it when I'm trying to get it past their tongue. And then once I get it past their tongue, they're fine. Yep. No, I've actually thought about it. Right. Right. And then some people will argue also, like with these studies that show that the intracranial pressure goes up by 200%, that sounds absolutely horrible, and it's reason to think that that's, like reason enough to give a paralytic, but there's been no correlation with increase in intracranial bleeds. So whether or not it's clinically significant plays a part also.
That's actually the second question that I want to say, that all of these things that are quite well known, that all these changes in the vital signs and mechanical pressure, but they don't have any measure of side effect on the child. Because I remember at the time that was still very debatable in the mid to late 90s, there were actually several studies, including one that was done at the Jefferson Healthcare System, that were doing a trial with pre-medication without intubation. Pre-medication, actually the trial was interrupted prematurely because we had a much more significant side effect in the pre-medication. So we could not even complete the enrollment target because it was found that it was so unsafe to do that we couldn't even continue the trial.
I think it all goes back to your belief in what babies feel and whether or not it's humane. Because Keith Barrington, like I said, has written an editorial also that says you would never, ever conceive of intubating an adult or a child without premedication. And so can you conceive of that in a baby? And whether or not that's humane. So it kind of all goes back to what's your lesser of your evils. There's short-term, long-term outcomes. So Ann Taddeo is very interested in neonatal pain, too, and she's written done several studies that have looked at the baby's responses to circumcision and also to to their immunizations at 2, 4, and 6 months in the clinic, based on whether or not they were circumcised or not in the hospital, and whether or not they were IDM babies that had routine many glucose heel stick checks. And she found that those were 2 separate studies. She found that the babies that were circumcised had more adverse reactions to their immunizations in the clinic at 2, 4, and 6 months. And then also the babies that were IDM babies that had multiple heel sticks for their glucose checks had more significant adverse reactions to their immunizations. In terms of further out than that, I've not seen literature.
Our Institute of Child Development is looking at the question, child psychology, but maybe better specifically looking at cortisol release, if you measure salivary cortisol, changes in the axis for long periods of time. So there's some suggestion that physiology does change with whether it determines which kindergarten or college you go to. That's it. One of the things that was interesting about your study was the use of various criteria for degree of hypoxia. And we get asked on the unit a lot about whether apnea causes any long-term developmental deficits. There are no studies to show that. The best that we actually have is Doppler ultrasound of the cerebral vessels during apnea spells. And 70 is, we use 75, I think, but 70 or 75 is kind of a magic number. If your heart rate drops below 70 or your SATs drop below 75 or 70, you start to see reversal of Doppler flow. So at least you know that there are some cerebral changes that are taking place, and probably rather not do that than do that. More questions? Well, Kari, thank you very much.
All right, thanks for coming.